Good morning, good afternoon, and good evening to everybody. And thank you for joining us, and welcome to this fifth webinar in our series on the MedSense Nociception Monitoring Index. I am Frank Overdyk. I'm an anesthesiologist and the consultant medical director for MedSense here in snowy, icy Charleston, South Carolina. Our previous four webinars covered a series of different topics on how continuous nociception monitoring in real time can help improve your dosing of opioids and analgesics and improve your patient outcomes. You will find the previous four webinars on YouTube describing how nociception monitoring can be especially helpful when caring for bariatric patients, how NOL monitoring can help you evaluate the adequacy of your regional nerve blocks, and the other benefits of personalizing your opioid dosing to a real-time physiologic signal from the patient, as opposed to just using body weight-based dosing, which in 2025 seems kind of outdated. I'm convinced that if you try this device, especially in patients who may be difficult to dose, such as the obese, the elderly, the opioid-tolerant patients, you'll find this monitor extremely valuable. But don't take my word for it. You will find the webinars I mentioned online, where experts from all over the world, from Canada, France, Italy, Spain, the Netherlands, explain why they became fans of this monitor in particular. As much as the practice of anesthesia is the same in all our countries, it also differs in significant ways. For example, in Japan, they do not use a post-anesthesia care unit or a PACU as part of the perioperative surgical care pathway. The patients are discharged directly from the OR to the ward, where they have 5 or 6 patients to nursing ratios. Today, we will hear from a Japanese expert why and how nociception monitoring is extremely valuable in this practice setting. We have with us Professor Nobuhiro Tanaka, who is a junior associate professor and senior lecturer at Nara Medical University in Kashihara, Japan. Professor Tanaka's interests and expertise are in regional anesthesia and cerebral oxygenation, and he became interested in nociception monitoring back in 2022. He has been using the NOL monitor as a clinical adjunct for 3 years and is firmly convinced that this monitor is the last piece of the puzzle for monitoring all 3 elements of anesthesia and will improve your patient outcomes as well. Professor Tanaka, welcome.
Hi, everyone. My name is Nobuhiro Tanaka from the Department of Anesthesiology at Nara Medical University. I was given the opportunity to give a valuable lecture by MedSense and Dr. Overdyk. I would like to express my sincere gratitude. Thank you, Dr. Overdyk.
Thank you, Dr. Tanaka. We're delighted to have you and get your perspective. As I said, we're getting perspectives from clinicians all over the world, and yours is going to be invaluable and very helpful as well. So any questions that come up from the audience during this talk, please put them in the Q&A box in Zoom, and we will address them at the end of today's session. Now, I'm going to spend the first 15 minutes or so introducing this monitor to those of you on this call who are new to the concept of nociception monitoring and this device specifically. So here's the triad of anesthesia, of objectives. We are responsible for providing these 3 components of the anesthetic. Since the 1970s, we've had an objective monitor of muscle relaxation, the Trainer 4 monitor, which is now available as a much improved quantitative monitor of neuromuscular blockade. Let me just... in the 90s, we got our first depth of anesthesia monitor, the BIS monitor. We now have several technologies intended to measure depth of anesthesia and SedLine, Narcotrend, etc. But we have never had an objective monitor for guiding the dosing of analgesics specifically. I got Dr. Tanaka on there, and I think I need to, people like to see me as well. So we are going to address today this third element of analgesia. How do we objectively monitor analgesia with a monitor? We use surrogate vital signs, typically heart rate and blood pressure, but these are not necessarily indicative of pain or nociception in patients and may be false positives in patients with essential hypertension, on beta blockers, etc. Pain is a subjective sensation which can only be quantified by asking the patient. But under anesthesia, the patient is unconscious and they can't tell us their pain level. Thus, we use a term nociception as the surrogate for pain. Nociception during surgery is manifest by the activation of the sympathetic nervous system. Our blood pressure and heart rate increase, our pupils dilate, our skin starts to sweat, etc. We traditionally look at blood pressure and heart rate as the primary surrogate measures of nociception and to guide administration of analgesics, typically opioids. But why not you monitor directly organ systems such as the blood vessels, the heart, and the skin to be able to tell what the level of sympathetic stimulation is. So here we have the finger probe. The NOL uses this finger probe to sense changes in sympathetic tone from the blood vessels, the heart, and the skin, and to quantify the amount of unopposed stimulus. I'm going to try one more time to minimize that so we can see the rest of the slide. Excuse me. There we go. So what does this sensor measure? The sensor basically sits in a cradle attached to the finger. It measures the photoplethysmograph, or the PPG, which everyone's familiar with because that's the same signal from which we derive the oxygen saturation. But with this probe, it does not measure oxygen saturation. It uses a single light frequency. It measures the pleth amplitude, the heart rates, and then we have the skin conductance is measured as well by the PSG over there. The machine learning algorithm calculates the nociception index from these values and their derivatives. It senses temperature and movement as well. You see the accelerometer, but only to establish operational limits for the monitor, not as part of the NOL index determination. I'm going to give you a high-level description of how this monitor uses these signals to derive a continuous measure of net surgical stimulation during anesthesia. We call this the nociception anti-nociception balance, or the NANB. Now, I say net because the monitor gets a signal from the patient that is proportional to the amount of surgical stimulation minus the amount of analgesia provided by the opioid analgesic on board that you've used for dosing. So the NOL monitor uses this machine learning language called random forest that is trained by presenting it with thousands of samples of these four physiologic signals from stimuli of various intensities obtained during 200 plus surgical cases. Now, we know that intubation is a severe nociceptive stimulus. So the signals during these cases, the signals that we saw during these 200 cases were labeled as severe. We also know that surgical skin closure is a mild nociceptive event. So we label those as such. This is why this process is called labeled or supervised machine learning technique. This way, the model, this big data set, is taught what pain or nociception looks like in terms of these physiologic symptoms from the sympathetic nervous system. We call this a forest because each of these sets of physiologic parameters can be thought of as an expert tree, describing that moment in time, and all these expert trees together become a forest. What happens in real time during your case is that every second the finger probe presents a set of data to the experts decide which intensity of stimulation best fits the profile. So let me give you an example. Let's say your heart rate on the tree to the left spikes to 130, and the galvanic skin response decreases to less than 8, patient sweating. This first expert is going to go down their tree, and it's going to decide that this is severe pain. Now, the second expert, the next tree, has a slightly different characterization of pain based on what it gathered during those 200 test cases, starting with the pleth amplitude, and based on its thresholds, it'll decide at each decision that what the level of stimulation is, and it also ends up with severe pain. So you can see we have these thousands of trees, or there we have a picture of thousands of anesthesia experts, and they decide, and then there's sort of a democratic vote on what is the most modal or the most popular level of stimulation. Now, I've just explained this in terms of 4 levels of stimulation, but that's not how the NOL works. The NOL is a continuous scale. It goes from 0, no nociception, to 100, extreme nociception. It's not a linear scale. I put this, made a little squiggly line here to show you that it just means that a NOL of 50 does not mean twice the nociception of a NOL of 25. The index is an ordinal scale, which means that a higher number is likely a greater stimulus than a lower number. And as with any continuous monitor, we look for patterns and trends. But very important here as well, a ROC or receiver operator analysis of this data was done to optimize the sensitivity and specificity for distinguishing noxious stimuli from non-noxious stimuli. And that ROC analysis gave us a NOL threshold of 25. You see the solid red line. So if the NOL threshold is greater than 25, consider giving more analgesics. If it's less, consider giving less, or taking away if you're using a continuous infusion of remifentanil. Now, how well does this NOL index reflect different levels of stimulation compared to heart rate and blood pressure that we always use? Chris Martini in Leiden took 3 discrete levels of stimulation, skin prep, incision, and intubation. You see the 3 discrete levels here, and measure how well do heart rate, mean arterial blood pressure, and the NOL index distinguish between these stimuli. They added the bispectral index up here on the bottom left as a control, because in a properly anesthetized patient, you see this patient has a BIS between 40 and 60, that patient should not have any changes, should not be able to distinguish any of these stimuli. And you can see that here, that while during these stimuli, the BIS index does nothing. Heart rate goes a little better. It can distinguish intubation with an increase in heart rate, but incision is not that consistent increase. Blood pressure, mean arterial blood pressure, does a little bit better. As you can see, both incision and intubation have increasing slopes, but the best monitor for detecting the level of stimulation is the NOL index. As you can see here, proportional increases in the metric based on the threshold of stimulation. Now, I know what you're saying. You're saying, well, this is all very nice, but the model was trained on 200 patients, and my patient doesn't look anything like these 200 patients. So Dr. Kurt Roetzler at the Cleveland Clinic pulled together all the raw data from a bunch of NOL studies, and he was looked into how generalizable is this NOL index, and how, most importantly, how generalizable is that threshold of 25, my apologies, the red line. He sliced the groups. He took all this data, pulled it together, and sliced it by age, by sex, by BMI, ASA status, and the type of inhaled anesthetic and opioid used. How well did the NOL index threshold of 25 hold as a binary differentiator between pain and no pain across these demographics? And as you can see, it held up quite well in all these groups, as shown by the box and whisker plots. It's a little bit of a busy slide, but let me start with top left. Here we're comparing female to male. Here's the 2 boxes for the 2 non-noxious stimuli, and you can see that NOL values are low, and they're both below the threshold of 25. For noxious stimuli, they do better. You see here, we have the noxious stimuli be it an incision or an intubation, we see the NOL value goes above the threshold. Similarly, we have the same for the age under 65 here, the non-noxious stimuli. Both patients under 65 and over 65 had NOL values under 25. And when they received a noxious stimuli such as incision or intubation, their NOL indices went up. You can do the same analogy here. You see for overweight, normal weight, overweight, and obese, NOLs less than 25. During stimulation, NOLs greater than 25. Here we have it characterized by DES, by SIVO or by propofol anesthesia, by ASA status, and here we also have by type of opioid, remifentanil versus fentanyl. So remarkably consistent, the NOL, these relationships held, the ability of NOL to differentiate noxious from non-noxious stimuli during different types of anesthetic was actually quite robust across the population. We are now going to have our special guest, Dr. Tanaka, share with us his journey with the NOL index. And at the conclusion of this presentation, we will answer some of your questions. So Dr. Tanaka, welcome again. And please share your slide deck.
Okay. Dr. Overdyk, can you see this slide?
Yes, we totally looks good.
Okay. Let's
Just
start.
maybe you have to maximize the screen because I still see my slide. Okay, yeah, or that might be me. No, I think you're good. Never mind. Go ahead.
Thank you, Dr. Overdyk. Hello, everyone. A little bit late. Happy New Year to all of you. Since I was given a wonderful topic of discussion, I would like to share it with you based on my research results. I would like to inform everyone that there are no conflicts of interest to declare for this presentation. First, let me introduce the Japanese medical environment for your understanding. To everyone's surprise, there are almost no post-anesthesia care unit in Japan, the percentage of which is said to be 16.1%. In addition, as I will discuss later, there is only one nociception monitor approved in Japan. The status of opioid use in Japan is characterized by strict laws and high hurdles in order to prescribe them. Both physicians and patients are reportedly reluctant to use opioids and tend to prefer non-opioid analgesic management. 83.9% of hospitals in Japan do not have PACUs. The system is designed to return patients directly to the hospital ward after confirming that their respiratory status and circulation is stable. And we Japanese are aware that this is inefficient in terms of system operation. However, many hospitals find it difficult to manage PACUs due to the fact that their medical fees are not paid at all. And there is a lack of manpower due to the proliferation of small hospitals. Again, due to the lack of PACUs, we Japanese anesthesiologists have to quickly balance appropriate analgesia with stable respiratory status and circulatory dynamics in the operating room. In this slide, I'll be explaining the nociception monitors currently available in Japan. There are 4 types of representative nociception monitors that have been published in the journal titled Anesthesia and Analgesia. Of these, the only monitor that is currently available in Japan is the Analgesia Nociception Index. However, its name Analgesia Nociception Index is not approved in Japan and is therefore sold under the name High-Frequency Variability Index. To avoid confusion, I'd like to remind the audience that they are the same things in principle. The measurement method is also unique, and unlike in Europe, there is no monitor dedicated to analgesia nociception index, so it is used by connecting it to the roots system from Massimo. It is said that an application for approval of the PMD200 will be made in Japan in the future, and that it will not be possible to use it in clinical practice until 2026 at the earliest. Truthfully speaking, my area of expertise is regional anesthesia, and I am interested in a novel nerve block called mTAPA, officially called the modified abdominal nervous block through pericondyal approach. At the 10th costal cartilage level, the local anesthetic is administered between the internal oblique muscle and the transversus abdominis muscle. With one puncture per side, a wide range of analgesic area can be obtained from T7 to 11 intercostal nerve anterior cutaneous branch area. If you don't mind, I'd like you all to please take a look at the video. As you can see, the needle is inserted below the 10th costal cartilage, and the local anesthetic is administered between the internal oblique muscle and transverse abdominis muscle. mTAPA can only control somatic pain, and in abdominal surgery, opioids are required to control visceral pain. However, since opioid overdose can cause opioid-induced hyperalgesia, I was always in search of an objective indicator proving proper opioid administration. A paper by Dr. Funk, published in the British Journal of Anesthesia in 2021, first introduced me to the existence of the nociception monitor. This is a keynote for my research. I thought that if I use the monitor introduced in this paper, I could easily start research regarding regional anesthesia. But in reality, there was no strong evidence, and I felt that research on nociception monitor was a blue ocean. This is a well-known research paper for doctors interested in NOL, but I would like to introduce it to you. This is a 4-group comparative study of male patients aged over 18 who are undergoing radical prostatectomy. The remifentanil consumption using the surgical place index, pupillometry, PPI, and NOL as indicators was compared with the remifentanil consumption in the control groups. One thing worth noting is that cortisol and ACTH are also examined. Here is the result for the primary endpoint. Remifentanil consumption was highest in the SPI group, followed by the control, NOL, and PPI. In the SPI group, the administration patterns exceeded 0.6 microgram per kilogram per minute at 180 minutes after the start of surgery. And the PPI group, the pattern was to manage it at less than 0.1 microgram per kilogram minute early after the start of surgery. And from a clinical standpoint, these patterns feel a little strange. Among the secondary endpoints, I was particularly interested in the results for cortisol. Again, the order of remifentanil consumption was SPI, control, NOL, PPI, but the order of cortisol level was reversed. In other words, the SPI group, which received the highest dose of remifentanil, has the lowest cortisol. On the other hand, the PPI group has the highest. The NOL group also had higher cortisol level than the SPI and control. In considering the reason for this, I thought the key lay in the protocol. The protocol was to allow 0 remifentanil during laparotomy, radical prostatectomy. When intraoperative average remifentanil was managed below 0.2 microgram per kilogram per minute, cortisol began to increase, especially markedly below 0.1 microgram per kilogram per minute. Scattered in the PPI and the NOL groups, and the number of patients in which remifentanil stopped was higher. However, there is a controversy around whether cortisol can be trusted as a stress marker. First, cortisol is a hormone with diurnal variations. Second, there exists a study suggesting that interleukin-6 and CLP more accurately reflect surgical invasiveness than cortisol. With these points in mind, we planned our study. It was a difficult problem to obtain permission from the Japanese Ministry of Health, Labor, and Welfare to start the study using the PMD200, still approved in Japan. Once again, I would like to thank the staff who worked with us. Our study included male patients undergoing robot-assisted laparoscopic radical prostatectomy. We developed an analgesic management protocol using NOL as the indicator and compared remifentanil consumption to a control group. As a side note, we then decided to examine interleukin-6, increasing the study's novelty. As a side note, we chose a NOLDOR as the initials of this research. NOLDOR is a reference to the elf that symbolizes erudition in J.R.R. Tolkien's Lord of the Rings. And I'm proud to say that it is a preferred name for the PMD200 that is worn on a finger. Here is a protocol. Remifentanil will be started at 0.2 microgram per kilogram per minute, reduced to 0.05 microgram per kilogram minute after intubation, and then started again at 0.2 microgram per kilogram per minute for management as surgery begins. After the start of surgery, the NOL is used as the index for management. And when the NOL exceeds 25, a bolus of 30 microgram is administered, increasing in 0.03 microgram per kilogram a minute increments. Conversely, if the NOL is less than 10, decrease the dose by 0.03 microgram per kilogram per minute. Based on Funk's study, the protocol is to maintain remifentanil above 0.11 microgram per kilogram per minute without reducing it to 0. The control group was our usual management. In addition to remifentanil, we used an average of 350 microgram of fentanyl in robot-assisted laparoscopic radical prostatectomy over the 2-year data period beginning in 2020. In order to align intraoperative fentanyl consumption with the control group in the intervention group, fentanyl was administered at these separate time points at the time of intubation and intubation and at the start of surgery and at wound closure for post-operative analgesia. Here is the result for the primary endpoint. The mean intraoperative remifentanil dose was 0.162 microgram per kilogram per minute in the control group, compared to 0.125 microgram per kilogram per minute in the NOL intervention group, a difference of 0.038 microgram per kilogram per minute between the groups. There are no findings that define a clinically significant difference in the amount of intraoperative remifentanil. It is difficult to determine whether the difference has clinical significance. However, I think it can be said that we succeeded in reducing the amount of intraoperative remifentanil consumption by approximately 20% compared to the control. As per our initial hypothesis, the amount of fentanyl used was almost same. Please see the changes in the remfentanil flow rate over time. In the NOL group, the flow rate reaches 0.11 microgram per kilogram per minute in the early stages and remains stable. In the control groups, it appears that they administered a larger dose of remfentanil around the time of insufflation was started in order to stabilize the circulation. Here is a spaghetti plot graph. The NOL group was able to follow the protocol and lower the dose to 0.11 microgram per kilogram per minute early. In a few cases, we increased or decreased remfentanil, but the pattern is almost uniform. In contrast, the control group showed a variety of dosing patterns selected at the discretion of each anesthesiologist. Here are the results of secondary endpoints, which were examined for stress markers. There were no significant difference between the two groups in interleukin-6, CRP, or cortisol. In my opinion, taking Funk's result into account, I have the impression that the cortisol and remfentanil consumption have an inverse relationship. Next, here are the results of the pain scores using the numerical rating scale. There was a significant difference after post-operative day 1. There was a significant difference in the NOS score at least 2 hours post-operatively, but there was no significant difference after post-operative day 1. Surprisingly, the NRS score on movement was lower in the NOL intervention group until post-operative day 3. The fact that the NRS score remained below 4 is in line with the ERAS protocol, showing a favorable result. This has become rather long. I will summarize the main research results here. Compared to normal management, NOL-directed management reduced intraoperative remfentanil consumption by 20% without causing an increase in stress markers. In addition, it improved the resting numerical rating scale at 2 hours post-operatively and the dynamic NRS for pain until 3 days post-operatively. I hope to receive a good impression from you all today. However, I have still received some tough comments from reviewers. It was difficult to get an understanding of the protocol by mixing fentanyl and remfentanil. The reason for this is, as I explained before, there is no PAC use in Japan. I would like to examine from a different angle whether or not the protocol based on remfentanil and adding fentanyl at highly invasive times were really effective. This is an unpublished data comparing the change in NOL before and after intubation and at the start of insufflation between the two groups. We use a method called interrupted time series analysis to observe the impact of specific events and investigated the level item in the analysis. Briefly, the survey asked how much the NOL was changed by the intubation. For all patient statistics, NOL increased by 22.9. The time before intubation, the NOL intervention group started with an average of 9.93, a lower value than control group. The increase in intubation itself was not different between two groups. It is possible that intubation was uniformly invasive, perhaps due to the use of the video laryngoscope as a protocol. As a result, the NOL intervention group showed less of a trend toward lower post-intubation NOL values than the control group did. A difference of peak NOL value was 10. Pre and post insufflation were also examined. Just before insufflation, the NOL intervention group started with an average of 6.48 once again, a value lower than the control group. The difference of peak NOL after insufflation was 10.76. NOL intervention were able to suppress the NOL peak after 5 minutes of insufflation. This shows the distribution of the proportion of time spent in the following ranges: NOL less than 10, NOL between 10 and 25, and NOL 26 or more. While there was an error in the table presented in our original article, this one here is a correct distribution. In the NOL group, the time spent below NOL 10 was high, and the time spent above NOL 26 was low. Regarding the suitability of the lowest remifentanil flow rate of 0.11 microgram per kilogram per minute, the reviewers pointed out that because this was a robot surgery rather than a laparotomy, it would have been better to set it a little lower in terms of invasiveness. However, I think it was more appropriate than the control group. I admit that there is some potential for improvement, but I had the impression that the effect of NOL would be increased by creating a protocol. Some Japanese people have heard of the opioid crisis in the United States. It seems natural that opioid-free anesthesia is attracting attention, but a paper published in JAMA Surgery last year raised questions about the opioid-free and opioid-sparing anesthesia trends. This paper suggests that the post-operative course is improved by the appropriate intraoperative use of opioids. I believe that opioid use is important to control surgical invasiveness, and while opioid sparing is important, I also believe that optimization is too, in order to adjust opioid use timing. According to this article, the post-operative outcome can be improved by using opioids appropriately during surgery. I believe that the use of opioids is important to control surgical invasion, which is an extraordinary nociception, and while opioid sparing is important, I believe that optimization, which is titrating opioids according to the degree of invasion, is important. I think NOL must be a game changer as a flagship of new trend. Moving on, please allow me to introduce a few recent topics in Japan. Assistive, which controls total intravenous anesthesia using software, was released by Nihon Koden in 2023. Propofol, remifentanil, and rocuronium were administered based on simulation results of effect site concentration as well as various monitors. Currently, usage is limited when an anesthesiologist is present. In Japan, where manpower is in short supply, this is a technology that is expected to be put to use in the future. Anesthesia is achieved through 3 elements: hypnosis, muscle relaxation, and analgesia. As a feature of assistive, hypnosis and muscle relaxation are monitored using the bispectral index and triennial 4, respectively, but there is no specific monitor for analgesia. An appropriate analgesic state is defined as one in which there are no sudden changes in circulation. Specifically, it seems that inadequate analgesia is judged as a state in which there is a 20% increase from the average systolic blood pressure and heart rate in the last 4 minutes. In the clinical trial stage, it has been reported that under these rules, remifentanil was often administered at a rate of from 0.7 to 1.2 microgram per kilogram per minute, or a maximum rate of 2 microgram per kilogram per minute, an extraordinarily high flow rate. which is quite different from what clinical anesthesiologists may expect. I am very interested in how things will develop in the future, such as whether nociception monitors like NOL will be incorporated. Based on the research I've introduced, I would now like to share the research I am currently working on with you all. We are conducting a randomized controlled trial of patients undergoing total laparoscopic hysterectomy using almost the same protocol as RALPH. Again, the primary endpoint is a remifentanil consumption, but the feature of this study is that it is a three-group comparison of the NOL, high-frequency variability index, and control groups. As with previous study, this study also measured stress markers such as interleukin-6, CRP, and cortisol. Before presenting the second new study, let's briefly introduce the results of another sub-analysis. Chronic post-surgical pain is defined as pain that persists for 3 months after surgery. Robot-assisted laparoscopic radical prostatectomy showed chronic post-surgical pain in 14% of patients. Although the sample size was small, there was no significant difference between with and without NOL intervention. Pain on movement at 2 hours post-operatively was identified as a factor contributing to a CPSP. Regarding this factor, we have set it as an outcome for the next study, which I will introduce it next slide. We have also started to investigate the usefulness of whether the NOL-directed analgesic management protocol can be further improved by adding continuous intravenous lidocaine during surgery to suppress pain during movement. We look forward to the results of these two RCTs. And finally, just a little take-home message to minimize patient pain. NOL-directed analgesic management was useful in robot-assisted laparoscopic radical prostatectomy. NOL may be more effective when utilized in conjunction with protocol. Opioid titration, a new strategy to adjust the intensity and timing of analgesic administration, may become a new trend, and NOL is essential to opioid titration. Thank you so much, everyone, for your attention. I look forward to seeing you all again in the future. Thank you very much.
Excellent presentation, Dr. Tanaka. Very, very interesting. You really stimulated a lot of different areas of thought. First of all, congratulations on all the acronyms. NOLDOR from J.A. Tolkien is fabulous. Optimist, I like that one too. What strikes me is how you've tried to tie together opioid consumption, pain, postoperative pain, and stress in all these things. And they're very much related. I was actually fascinated by the fact that the pain scores, post-op pain scores, day 1 through 3 were decreased. Yeah. I was trying to think why that is. And that was very important because you're chronic post-surgical pain patients. Those are the patients where we can have a real impact on their quality of life many days after they're discharged. What do you think is that relationship, if I can ask you to sort of theorize as to why it is? You're looking into it with your new study, but that prolonged improvement with NOL to have decreased pain upon movement.
Yeah, I think the acute post-operative pain care is very important. Yeah, I said moment-to-moment control of opioids is very important for the patient. Yeah.
You mentioned opioid-free anesthesia, and I think you are of the opinion that as I am, as many people are, that opioid-free may be a little too far to one side, and we're better using this monitor to give us just the right dose of analgesia at the right time, personalized to that patient, as opposed to some weight-based or other regimen. Is that true?
I think so. Yeah, that's right.
Yeah. Okay. All right. A couple of questions that I had that I asked most of our experts. What patient groups would you think NOL-guided analgesia is most likely to be helpful for?
Oh, thank you for your question. The administration of intraoperative opioids to obese patients is always a difficult issue, with some arguing that they should be calculated and administered based on ideal body weight, while others argue on corrected body weight. Ultimately, however, it is important to optimize the dose, and NOL-directed optimization will be a great benefit to obese patients. For me, who prefers peripheral nerve block of the trunk, I can control somatic pain to some extent with nerve block during surgery. But I also think that NOL is the best indicator for opioid titration during surgical procedures that involve visceral pain. Although the target is not patient, I think that many Japanese anesthesiologists use relatively large amounts of remfentanil to prevent patients from experiencing intraoperative pain. And NOL has great significance in preventing the indiscriminate use of large amounts of opioids.
Yeah, you mentioned that in your last slide there, that they tend to turn the Remi up to 0.2 mics per kilo per minute and leave it there, as opposed to titrating it.
Yes.
And that's what we have noticed as well across the world, where people, once they see that they want to increase the Remi, they're reluctant to turn it down without any signals. Now, to your point in one of your slides, the Funky
Yes.
study turned off the remifentanil, which is not what we recommend or what you should do, because the NOL monitor cannot anticipate surgical stimulation. It's not forward-looking. You should always keep a baseline level of remifentanil, as you did in your study. And that's probably the reason why in that study there was more movement, but that's not surprising. Keep a baseline, but you can decrease the amount of remifentanil. You were consistent. Dr. Dahan in Holland has shown a 30% decrease in Remi. You showed a 20% decrease in remifentanil infusion over the cases. So those are all very consistent. Let me ask you another question. You talked about reduced stress response. Or actually, in your study, you showed that the stress response is not higher based on the hormones. Dr. Dahan showed actually that the stress response was lower by giving the right dose at the right time. In what way will that decreased stress response be manifest in terms of patient outcomes? In other words, is it going to be better wound healing? Is it going to be less hemodynamic variability intra-op or post-op? What do you think is the benefit of less stress hormone?
Yeah, thank you for your question. I think that the changes in stress markers this time have provided evidence that our protocol is not doing anything unconventional, even though we have reduced the remfentanil. Moreover, I believe that not only reducing opioids, but also adjusting them at the right time may reduce post-operative pain. I strongly believe that this will lead to the suppression of chronic post-surgical pain. I intend to continue researching this point at the current moment, as well as in the future. Thank you for your, yeah.
Yeah, and that's that's obviously a tremendous benefit. Are there any clinical situations and where you think the NOL number surprised you, that it went up when it shouldn't have gone up, or went down when you didn't think it was going to go down? Are there any clinical situations where you think the NOL didn't see what you expected it to do?
Yeah, yeah, no always no value move as I expected. I think it's a great machine. Yeah.
Yeah. And again, patient population. So in America, obviously, we have opioid tolerant patients, and obesity is quite prevalent. So those are the patients where we think personalizing the anesthetic is very important, personalizing the analgesic dosing. There's too much variability, and too often we have patients coming to the PACU with a high pain score, which
Yeah.
in my mind is sort of a failure of our anesthetic plan. Are there any, you mentioned your regional blocks. We've had a talk on regional blocks. You do a version of the TAP block there. Any other
Yeah.
blocks, any other peripheral or limb blocks, or that you think would be useful to use the NOL?
I want to investigate the relationship between the paravertebral block and NOL in the thoracic surgery. I'm interested in the combination. I want to investigate this combination, maybe suppress the CPSP. Yeah.
Okay. Yeah. We've had on the webinars surgeons from Germany and Italy who, during VAT surgery, video-assisted thoracoscopic surgery, thoracic surgery, they like to use the NOL to know when they can supplement their paravertebral blocks, and to see the adequacy of their regional block, which is really, really important. So anybody interested in that particular topic should go back to that and look at those webinars. You mentioned, so 2026 is likely that we're going to get further approval in Japan for you to use it routinely in Japan. You'll be doing research until that time to establish other clinical value, right?
Yeah, right. That's right.
Okay, good. Well, this has been where we're a little, let's see if I got any questions on the forum here. I got all my questions answered. Okay. In the titration of adjuvant analgesia, such as lidocaine, dexmedetomidine, ketamine, esmolol, magnesium. Okay, so I think the question here from one of the audience members is the nociception level index monitor specific to opioids? And if we think back at the mechanism of what the NOL tells us, it tells us sympathetic response, activation of the sympathetic response. So any analgesic that's effective, lidocaine, there's actually been a study done with dexmedetomidine. The NOL will reflect those analgesics as well. So it is not specific to opioids. Obviously, clearly we use opioids as our primary analgesic, but ketamine, studies have been done with ketamine. So if you ran a ketamine infusion or a lidocaine infusion, which a lot of people like to do in combination now, you can use the NOL to look at the influence of that infusion and that dosing on the patient's level of stimuli, nociceptive stimuli. Let's see if we have any other questions from the audience. One more question I had for you about your flow. You do not have post-anesthesia care units. So do you think, and you use primarily fentanyl for your longer acting opioid in Japan?
Yes. Yeah, fentanyl is a main analgesic. Yeah.
You're right, but for post-op, so you're going from the operating room right to the to the floor, right? To the ward. And do you use morphine or hydromorphone dilaudid?
There is not popular hydromorphone. We use acetaminophen. 6 hours per 6 hours,
Okay.
and using the NSAIDs.
Yeah. So
Yeah.
opioid sparing, you use a lot of opioid sparing modalities, and I imagine ketamine and lidocaine and Precedex are part of those opioid sparing techniques. And you have ERAS protocols. Do you think
Yes.
the NOL will be an important part of an ERAS protocol, early recovery after surgery?
I'm think the very important NOL maybe very important role, plays important role in the ERAS protocol. Yeah.
Okay. Yeah, and I think people are looking at that as well. And obviously, it would be nice if we could have all our monitors integrated in one place to
Yes.
have that. Your research, so how big, you have several research programs going on with the NOL right now, right? And what is the timeline for more results from your group?
Now I conduct 2 RCTs. Yeah.
Yeah.
One total laparoscopic hysterectomy will be finished in I think this year end.
Mm-hmm.
And lidocaine and NOL, the research about the lidocaine and NOL is only started this month, so maybe take 2 years after. Yeah.
These are lidocaine infusions.
Infusions maybe finished the 2 years after.
Okay. Okay, so we got a little time, but there's plenty of time. Well, we are fascinated and impressed by all your research and all the progress you're making in these areas. Very interested in seeing how all these things work out. Certainly the influence of nociception real-time monitoring on post-surgical pain, chronic post-surgical pain, very, very important. We want to thank you for your time and your interest and your dedication to improving patient outcomes. This has been very interesting getting your perspective from Japan. We've had a lot of European perspectives and Canadian perspectives. Hopefully get some more US perspectives as the monitor gets rolled out. Thank you very much, Dr. Tanaka. I hope everyone enjoyed looking at seeing this webinar. You can see it online, I'm sure, and you can feel free to ask us any more questions offline and we'll try and get them answered. So with that, we're going to end it, and everybody stay warm, stay safe, and thank you for your participation.
Thank you very much.